Okay. Well, good evening, everyone. My name is Ria Suarez with the Cancer Support Community, and welcome to our webinar, Frankly Speaking About Cancer, Immunotherapy Advances in Melanoma, which is hosted by the Cancer Support Community in partnership with AIM at Melanoma, Melanoma International Foundation, Melanoma Research Alliance, and Melanoma Research Foundation, and sponsored by Bristol Myers Squibb. A brief Q&A session will follow the presentation. If anyone should require technical assistance during the webinar, please feel free to dial 1-866-229-3239 and dial option number 1. As a reminder, this conference is being recorded. So before we start, I'd like to go over a few housekeeping items. So as mentioned, today's call will be recorded and available on the Cancer Support Community website at www.cancersupportcommunity.org/webinars. The format of today's webinar will be as follows. Our presenters will be featured first, and then we will begin the Q&A portion. Thank you to those of you who submitted questions prior to the webinar as part of the registration form. If you'd like to ask additional questions, please feel free to type it into the Q&A box on the right. You may submit a question through the box at any time during the event. At the end of the webinar, you will be automatically redirected to the post-webinar survey. Please complete this survey as your input is of great value to us. The survey will only take a few minutes. I'd like to get started by giving some background information on the Cancer Support Community. We are an international nonprofit organization that provides social and emotional support to all people impacted by cancer. We formed in 2009 as a result of a merger between the Wellness Community and Gilda's Club Worldwide. And through that merger, we now provide the highest quality emotional and social support through our network of more than 50 local affiliates, 100 satellite locations, and online programs. Our mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. These are just a couple of the resources that we provide through our organization. If you'd like more information, feel free to call our Cancer Support Helpline at the number listed there, 888-793-9355. or feel free to visit our website at cancersupportcommunity.org. For today's webinar, we will provide an overview of melanoma and immunotherapy. We'll discuss the immune system and cancer, immunotherapy treatments for melanoma, clinical trials, side effects, tips to manage side effects, and then also the social and emotional impact of metastatic cancer. It's now my pleasure to introduce our featured speakers, Dr. April Salama, Grace Cherry, and Ellen Levine. Dr. Salama is a medical oncologist who specializes in treating patients with skin cancer. Her focus is on taking care of patients with advanced melanoma, as well as melanoma that is at high risk for recurrence after surgery. As the Associate Director of Clinical Research for the Melanoma Program, she oversees all melanoma clinical trials at Duke. She works with other researchers to design new treatments for patients with melanoma, using both immunotherapy and targeted drugs. Grace Cherry graduated from UCLA School of Nursing with a master's degree in oncology specialty. She's been an oncology nurse for 26 years. She is currently practicing at UCLA as a nurse practitioner for the melanoma program. Ellen Levine is a seasoned clinician who has been in the field of oncology social work for over 25 years. She became the program director at CSC Central New Jersey in 2006. Here, she is able to oversee and deliver a breadth of psychosocial support services for people affected by cancer. Ellen has her MSW from Rutgers School of Social Work with a concentration of administration, policy, and planning. Okay, at this time, I now turn the presentation over to Dr. Salama. Dr. Salama?
Thank you so much. So just to talk a little bit of a background about melanoma. So melanoma is a form of skin cancer of the cells that contain pigment in your skin. And unlike some of the more common forms of skin cancer, melanoma can be so dangerous because it has the potential to spread to other organs. The good news is that most melanomas, if they're caught early, they can be removed by a dermatologist or a surgeon and don't spread. So it's actually only the minority of patients that develop advanced disease. Once it spreads to other part of the body, it can be difficult to treat with things like surgery. And historically, it had been really difficult in terms of finding effective drug therapies for metastatic melanoma, and the outlook was really poor. But in recent years, we've been fortunate enough to have several new discoveries in both the area of targeted therapies as well as immunotherapy, which we're going to focus on tonight. Just to go over some important terms and definitions. So immuno-oncology refers to sort of the ever-expanding field of cancer research that really works to understand the immune system and how it interacts with cancers. And it's focused on finding ways of using your body's own immune system to treat or prevent cancer for people who are at high risk of recurrence. And immunotherapies just refer to a type of treatment that uses the immune system in some way to treat cancer, and it can actually be used to treat other diseases as well. Just to talk about the immune system and how it interacts with cancer. So normally your body works to defend itself against disease by using your immune system. It's a complex network. It includes blood cells, it includes tissues like lymph nodes and other organs, and they all communicate in a complex network to work together. Normally your immune system works to prevent and limit infection by recognizing and destroying foreign substances like bacteria or viruses, and hopefully abnormal cells like cancer. So your immune system is made up of a number of different cells, and white blood cells called T cells and B cells are important, and they play a key role in recognizing and attacking abnormal cells. So T cells are what we consider to really be the core of adaptive immunity, and a lot of the immunotherapies that we talk about in fighting cancer are really focused on activating T cells to target cancer. B cells or other types of white blood cells, they work to produce antibodies that can help recognize and attack specific invaders or other unhealthy cells that are damaged. And antigens just refer to a protein or a substance on the outside of an unhealthy cell that can sometimes be recognized by your immune system to trigger an immune response. And antibodies are substances produced by the immune system to help respond to antigens and attack foreign or unhealthy cells. The key to immunotherapy is to really make sure your immune system can work together in a coordinated fashion. So it requires a number of different steps. So first, your immune system has to be able to identify specific ways that cancer cells or other foreign cells are different from your normal cells. It has to understand the mechanisms by which cancer cells are able to sort of outsmart or escape detection from the immune system. And then it has to work to stimulate specific parts of your immune system that can have them take on a more aggressive role in killing cancer cells, including your T cells and B cells. Immunotherapy can be used to block specific growth factors that may be important for cancer growth. It can also be used to deliver cancer drugs directly to cancer cells. So some of the different treatments for melanoma that we're going to focus on, and that there are many different approaches that have been tried and investigated over the years. Many involve activating your T cells and to try to enhance your body's overall immune response. Historically, when we used to talk about immunotherapy, we were talking about cytokines. So this is the more traditional approach and a way to sort of boost the natural defense system in general. And I often describe it as sort of pressing the gas, so trying to activate things in a general way. interferon alpha is currently a cytokine, and it's currently FDA approved for the treatment of prevention of melanoma that's at high risk for recurrence. And then interleukin-2, or it's sometimes referred to as high-dose IL-2, is another type of immunotherapy that's been shown to have a partial response rate in a minority of patients, although those responses can potentially be durable. The problems have come from the fact that these treatments are associated with a lot of side effects, and as you can see, they end up not really benefiting the majority of patients that get them. Some of the newer approaches are based on a better understanding of how the immune system works and the different regulatory factors that are involved. So in talking about one of the first newer types of immunotherapy to become available is ipilimumab. We also call it IPI for short, and Yervoy is the brand name. This is an agent that really works to take a break off of your immune system, and it allows your immune system to become activated and target melanoma. It's been FDA approved for about 3 years now, and I tell people it usually benefits anywhere from about a quarter to a third of patients that take it, and what that means is about 10 to 15% of patients can have their tumors partially shrink, and another 10 to 15% of patients we see that their tumors don't grow or that they have stable disease. One of the most exciting things about immunotherapy is that the responses, if they do occur, tend to be durable, and there are many patients that have responses that have been ongoing for many years. The way that tumors respond to IPI tends to be a little bit different than what we think of from traditional chemotherapy. So there's this phenomenon of delayed responses. And we actually give all courses of IPI first before we usually check a scan. So that's 4 doses that are given every 3 weeks. And then we check a scan and see how patients are doing. And sometimes it can take several months to see a full response. Right now, the focus is on looking at clinical trials that are being done in combination with both targeted therapies and chemotherapies and vaccines, as well as other immunotherapies, to look at combining these to see if it can potentially benefit more patients and overcome drug resistance. Talking a little bit about PD-1, which I kind of call a cousin of IPI. So it's another type of immunotherapy that also works to focus a specific break on the immune system. And PD-1, we now know probably is more important in the actual tumor environment itself, and cancer cells, including melanoma cells, but as well as many other types of cancer, express a protein called PD-L1, and we think that's important in essentially helping these cells evade immune detection by your body's T cells. And essentially when these cells link up with your T cells, it allows them to essentially kind of hide from the body's immune response. There are now drugs that are PD-1 inhibitors, of which there are a few that are available, but they essentially block the cancer cell's ability to interact with PD-L1, and it essentially allows the T cells to become activated again, and then the cancer cells become visible to them, and they are able to find and destroy tumor cells. So PD-1 has generated a lot of excitement in just the field of melanoma and oncology in general. Some of the early clinical trials have shown that nearly a third or maybe slightly higher percentage of patients have a benefit from treatment. And I would say while it's still early, we are certainly seeing evidence that these responses can be durable and long-lasting. And I think even more encouraging is that in cases when other treatments haven't worked, including ipilimumab, we've seen that patients have been able to get benefit from PD-1 inhibitors. and it's garnered a lot of attention recently. But in the past year, the FDA granted nivolumab fast-track status, which we can talk about a little bit more, but that's one type of PD-1 antibody. And then recently, actually just about a week ago, the FDA granted approval to another PD-1 antibody, pembrolizumab, and that's been approved to treat patients with advanced melanoma, where they've tried things like ipilimumab or other types of targeted therapies, and they haven't worked. So that's all very kind of recent news here. Just to talk a little bit about clinical trials and how these have worked, and they've become so essential for helping get some of these drugs to the patients that need them. And right now, it's really the only way that we're able to help provide new treatments for patients, and it's kind of considered the gold standard in our field. Everything that gets approved through the FDA has gone through some form of clinical trial, and as oncologists, we feel that the best innovations, can often be offered through a clinical trial, and this is often the best option, especially with something like melanoma, where there have historically been so many limited treatment options, and it's certainly because of clinical trials that in the past 3 to 4 years here we've seen new therapies and new treatment options that are now becoming available for more and more patients. There are many types of clinical trials, and each clinical trial is designed specifically with certain goals in mind, but often the way trials are designed, especially some of the larger studies, once we know that a drug holds promise, is that patients may get a standard treatment, an investigational treatment, or we may be adding both together. So just talking about the process of going on a clinical trial, these are tightly regulated and reviewed by multiple people, so not just the investigators performing the study, but each institution has a review board to review studies. Patients are fully informed, and we go through a consent process with any patient that goes on a clinical trial. To kind of explain all of the risks and the benefits, and I think also other treatment options outside of a clinical trial, because I think that's always important that people understand all of their treatment options. Participation is always voluntary, and even though I tell patients that they've signed a consent, they have a right to leave a trial at any time. So I always say that it's not a contract. In terms of talking about who is eligible for clinical trials or who is eligible to receive immunotherapy, some of these newer agents, including ipilimumab and PD-1, they're currently approved for very specific indications. So ipilimumab is approved for treatment of unresectable stage 3C or stage 4 melanoma, so melanoma that has spread to other parts of the body and can't be removed by surgery. Some of the more traditional immunotherapies, as we talked about, are FDA approved, like interferon for patients whose disease is at high risk for recurring or spreading. Things like pembrolizumab, the newer PD-1 agents, they're not yet available as what we call sort of first-line therapy. So the FDA label requires that patients have tried other treatments and that those treatments haven't worked. But I would say with the current landscape of treatment options for melanoma, most patients with advanced melanoma are eligible for some form of immunotherapy treatment. And I always say it's important to talk to your doctor and a melanoma specialist to talk about what is the right specific treatment for you, and talking about specific side effects and what to expect. In talking about clinical trial development, it's known that many new drugs are made available by clinical trials, and that's how PD-1 really up until last week was available to patients with melanoma. And our standard is to try to compare the known treatment options to new approaches. So the best known option, patients often will ask me if they're getting a sugar pill or what's called a placebo, and that's kind of rarely done in clinical trials today when it's known that there's a drug that can help patients with melanoma. Trials help us figure out a number of important questions because I think because while we've made a lot of progress, I'll say that there's still many steps kind of left to go. So it helps us figure out which patients potentially benefit from treatment, to try to figure out why some patients don't respond to certain therapies or some respond better than others. It helps us figure out when the best time to give immunotherapies are. So now that we know some of these immunotherapies help treat advanced melanoma, some of the newer immunotherapies like IPI and PD-1 are being tested to see if they can prevent recurrence. And looking at how we can combine it with other types of therapy, so other drugs and other treatments, to try to maximize the potential benefits, but at the same time reduce the risk and minimize side effects. Another question is how long should we be giving treatment? How many treatments is enough? And then certainly continuing to follow up and answer questions about the short and long-term effects of immunotherapy. And talking about the average timeline for drug development for clinical trials, historically it's been really painstakingly slow because of all of the work that goes into things in the lab, and then the different phases of clinical testing, which usually includes sort of three main phases, with the phase 1 trial being the trial where it's the first time the drug is ever given to patients. The phase 2 trial is usually a little bit bigger a bigger number of patients, and then a phase 3 study is a large study that often takes hundreds of patients and many years to complete, and that has historically been the standard to get a drug approved and available to all patients, and that's something that's been changing rapidly in the past few years as we have better information up front about which drugs might work in which patients. And because of that, the FDA has created a process to gain faster approvals for new drugs. And some of these are largely administrative designations in terms of something being a fast-track drug or something being a breakthrough therapy. But largely, to be a fast-track drug, it can be based on just evidence of promise in the lab and that they're trying to address a condition that really there is no current treatment option or kind of an unmet need. A breakthrough therapy needs to demonstrate a little bit more evidence of clinical benefit and that it's potentially substantially better than what's currently available. And both of these can help lead to an accelerated approval process by which it allows drugs that are treating serious conditions to be approved based on early promising clinical trials, with the understanding that some of the bigger phase 3 trials will continue to be conducted and analyzed to get sort of the long-term follow-up that's really considered the standard of care. And so that leads me to conclude that's this section, and now I'd like to turn the presentation over to Grace. Grace?
Thank you, Dr. Salama. So when I talk about side effects of immunotherapy, I find that people, my patients, as well as other healthcare providers, including nurses, have visions that include side effects that are related to chemotherapy. And I probably was one of those people too, because for years and years we gave chemotherapy, and most of the time when we have visions of it, we know someone who's gone through chemo, or we've heard of it, or maybe we've seen it in a movie. But the side effects from immunotherapy are completely different from chemotherapy. Chemotherapy, by the way it acts, it destroys rapidly growing cells. So Depending on the regimen, there may be hair loss because hair is fast-growing. There may be lowered blood counts like the white cells and fevers because those are also fast-growing, or nausea, vomiting. With immunotherapy, we don't commonly see those side effects, or if we do, they might be different or mean differently. Immunotherapy, as Dr. Salama has eloquently explained, it enhances the immune system. So the side effects often include inflammatory side effects or the effects of the immune system on the normal cells. The presence or absence of side effects is not an indication that the drug is not working. We have no markers to tell us who will have side effects or who will not have side effects. And if someone has more severe or none at all, that doesn't mean that the drug is or is not working. With prompt intervention, we do find that they're very highly manageable. It's really important to let your doctors know. Rarely they can cause serious and severe side effects, but that's why it's really important to let your doctor know or your care provider know if you're having side effects. So I do find that the patients that do really well, one of the characteristics they have is that they try to learn about potential side effects. I have a really good example of this one. I have Mr. G, who I live in LA area, and that's where I work. He is in his 80s and lives alone with his wife, and they live in Mammoth, which is about a good 5 hours drive. He got ipilimumab, and prior to that, we told him about expected side effects. He is well in his 80s, and he knows when to call us. He knows to call us if it's for anything really, and if it's on a weekend, we want to make sure that he knows how to contact us, because if he happens to be one of these rare patients that have a rare side effect that is severe, we want him to know what to do. So, when he got the IPI, he only got the side effect of a rash, fortunately. But we were able to communicate really effectively, even though he lives far away. We continue to treat him, and he is doing well, and we continue, even though he's miles away. And I think that if someone like that in his 80s, very high functioning and able to get this treatment and other immunotherapy, it's quite possible. And I think that when patients know what to expect, that in general will help prepare them. The side effects for immunotherapy are different for ipilimumab and the anti-PD-1 inhibitors. And when I say that, I mean that the more common side effects, some of them are similar, but the rare side effects can also be similar. But we do know with ipilimumab the sequence as far as when they happen. Most people do not have side effects with PD-1 compared to ipilimumab, so they are different in that way. The less common side effects can affect other normal cells, which I have a slide on, but with prompt intervention and early reporting, they can be manageable. I'm only going to talk about ipilimumab right on this slide, and the only reason why I put CTLA-4 inhibitor is mainly because I want to convey that they are different checkpoints. It's not so much so someone can remember what it is, but the immunotherapies work differently because they affect a different checkpoint. So ipilimumab or Yervoy is a CTLA-4 inhibitor. One of the common side effects is fatigue. When patients complain of fatigue, I'm not talking about debilitating fatigue like chemotherapy. Most of our patients who are high functioning will continue to be high functioning. If they have a severe fatigue, that quickly alerts us that it's something else probably that's going on and that needs investigation. So when I say as far as fatigue as a common side effect, I'd like to convey that a lot of our patients continue to be high functioning. The more common ones are more of the mild fatigue. And certainly if it's more severe, which is uncommon, that will prompt other investigation to see what the cause is and that it's not just a treatment-related side effect. Another common side effect is a mild inflammation in the intestine, or what I hear from patients is sometimes they'll say they have abdominal pain or they have a watery stool, It might just be 1 or 2 times. They might have a heartburn. This is mild and it won't stop treatment per se, but certainly if it becomes severe means that, which is the rare one, severe means that patients are having watery stools, but in addition to that, they're having it really frequently, every hour or just nonstop. That is a very rare, serious side effect. But the more common one would be the milder form. So again, it's important to let your doctor or care provider know so we can investigate on it. We can see, is there an infection? We have to make sure if that's the case, and if it is, then we need to treat the infection, or is this from the inflammatory side effect? Another common side effect might be an inflammation of the thyroid, where there might be a hyperthyroid followed by a hypothyroid. Well, this is really easy to spot. What I do find is that most patients don't have side effects, but if they do, a more common one would be like fatigue or weight loss. When I say it's easy to spot, with ipilimumab, one of the things that we do is do a blood test, and in addition, we do a thyroid check test. So with the blood test, one can tell if someone's having a side effect from the AP that's affecting the thyroid. And then finally, we do know that a skin rash is also very common. Sometimes it could just be like a pinpoint red. It could be itching. It could cover the chest, the upper arms, the lower legs. Most of the time, it's very mild. It could also affect the mouth, or you can have blisters. But if it covers like a good portion of the body, that would be considered very serious, and it needs to be treated differently. Most of the time with the mild ones, it doesn't necessarily stop the treatment either. They can be easily managed with a topical steroid. But again, the one message that I want to convey is to always report your symptoms so they can be evaluated properly and managed properly. Okay. I'm trying to forward my slide, but it won't forward.
Do you want to try the arrow keys at the top?
I did.
Okay. I can advance for you.
Thank you.
Mm-hmm.
Okay, so it needs to go back to 32 because that's the anti-PD-1. So last week, the anti-PD-1 antibody was approved. It's called Keytruda and pembrolizumab. I don't necessarily expect people to remember this, but I do find that a lot of our patients are very well versed. This is the other inhibitor and also enhances the immune system to work. Again, it's the same thing with the ipilimumab. The fatigue that's common is very mild. I have patients that come, and I have a patient from Hawaii who I see him every 3 weeks. He's very high functioning. He'll say he has fatigue for 2 days, but he continues to do activities like running. It definitely isn't the fatigue that we see with chemotherapy. If it is that, or if it's severe, then that'll prompt us that there might be something else going on, and we need to investigate on it. There can also be elevated liver enzymes. This is very easy to spot. Before each treatment, we require that a blood test is done, so the liver enzymes are checked. I had a patient last week whose liver enzymes went up. He didn't even feel it. But if they're mild, like 1 or 2 times the upper limit normal, they continue the treatment. If it's severe, we stop the treatment. I had such a patient, and we did stop it, and then we investigate, why is it up? Why is it really high? And again, the really, really high ones are very rare. And when once we've kind of checked out, it's not because of other things. This particular patient, the liver enzymes went down. So again, it's the liver enzymes, as far as the inflammation, is easy to spot because the blood test will be checked prior to each treatment. Similar to IPI, there can be inflammation of the thyroid, which again can be revealed in a blood test, and this is checked with the anti-PD-1, like prior to each treatment, or maybe every other treatment is sufficient. Another skin change, which is not life-threatening, is a vitiligo or lightening of the skin. I had a patient the other day was so distraught because all of a sudden she noticed these white pigmentation on her torso, and I guess he was like, "Oh my God, what does this mean?" And we reassured her that this is not life-threatening. It means that the immune system, when they've done biopsies on the skin, they find that there's immune cells in there, and they're attacking the melanin or the pigmented cells, and that means that the immune system is working. The other common side effect is joint pain. Again, these are mild, and if it's severe, they have to be reported because they need to be treated differently. And then finally, the skin rash can also occur with anti-PD-1. This is a picture of one of my patients who had ipilimumab. It's a skin rash. It was treated effectively with topical steroids without any systemic steroids. So systemic means it might be a pill if it's severe or a high-dose IV. He never got that, and it went away with the topical treatment, and he completed ipilimumab. The reason why the steroid would be the treatment is because it calms the immune system down. And this is a picture of another one of my patients with vitiligo. Interestingly, this patient is on the pembrolizumab, and interestingly, he also had the skin actinic keratosis, which are thickening of the skin, which is a benign condition. They also went away, but in addition, he also had the vitiligo, which is a non-life-threatening side effect. And this vitiligo can be seen with either IPI or anti-PD-1. I'm sorry, but I had a slide where I was talking about rare side effects, and I really want to talk about that. I think, here it is. That's the one. No, I found it right here because these are the rare ones that I really want to also convey. So these are less common side effects from both IPI and anti-PD-1. They're very rare, and they can happen, and they may not happen. And again, it's because of the inflammation or the immune system that's affecting normal cells. The first one is of the eyes. It's called uveitis. One of my patients who had this was complaining of a burning and itching, blurry vision, and he had some redness on his eyes. It was treated effectively with a topical steroid. We had him see an ophthalmologist or an optometrist, and he continued with his treatment. The other one that's really rare is called pneumonitis, where there's an inflammation of the lungs. One example is one of my patients who came in the clinic. He drove in from Nevada to LA, which is a good, 6-hour drive. So he was able to drive in, and he's in his 50s, and he said the only thing he said when he walked in is, "I kind of felt out of breath." But he wasn't coughing, he wasn't short of breath, he looked really good. We happened to do a pulse ox, and normally, just because, he was, we had it there, and, we kind of know that this could be one side effect, but I don't know, maybe we were being ultra conservative too. But, normally he would be 98%, and then at that particular day it was 96. Still not alarming. We decided to do a chest x-ray. It's a very cheap test, inexpensive, and it showed suspicious for pneumonitis, and that was later confirmed with the CT scan, and then he was treated with some steroids and which quickly reversed the symptoms. Obviously, it could be more obvious, such as shortness of breath or cough, but it could also be subtle, such as with this one person. And again, it's a rare side effect that can be spotted and can be treated effectively. The other really rare side effects, but very serious, is the inflammation of the intestine or colitis. This is when patients are having watery diarrhea that is frequent, nonstop. Even though they're taking Imodium, they're still going. They're feeling weak because they're getting dehydrated. This is really an emergency. If someone has this on a weekend, don't wait until Monday. You have to inform someone. You have to call your oncologist or your care provider, seek attention. Don't wait, so that it could be treated appropriately, which in most times would be treated with some steroids. But then they can also look look at other things, such as infection. The other rare side effect is the inflammation of the hormone glands, the pituitary, adrenal, and thyroid. So I talked a lot about the thyroid. The pituitary and adrenal, patients that have inflammation of the pituitary, it's obvious that they have it. Actually, maybe it isn't so much, but most of the time it's very obvious. I had one patient in the last month complain of severe headaches. We did an MRI of the brain because of the severe headache, and it showed that the pituitary stalk, which is connected to the pituitary gland, is thickened. That is one diagnosis of it. There's also a blood test that can be checked, but more often than not, people who have an inflammation of the pituitary, they don't feel well. They're really fatigued. They feel weak. They might have nausea, vomiting. They might have headaches. They do not feel well at all, and that often prompts, by reporting this and not waiting, that'll prompt your doctor to think, oh, it might be that, and then they can go ahead and take the test and treat it appropriately. It's a rare side effect, but it can be easily spotted, and with early intervention, the patient will feel better with treatment. Adrenal gland also is responsible for cortisol, which is an important hormone in the body. Again, it might be subtle, where I had one patient who just had weight loss, and also just the main symptom that he always said was, I just don't feel good, or I don't have as much energy. The blood studies that would confirm this were always sort of borderline, and eventually they did become abnormal. Oftentimes when people have these inflammatory side effects in the hormone, we oftentimes ask that they see an endocrinologist too, because they can be quite complex, and then we rely on their expertise to help us manage them. But your doctor will certainly know, and again, if there's anything you can remember about what I'm saying now, the most important thing is to report your symptoms so they can be evaluated properly. The liver, a really rare side effect that it will be severe, where the liver function is really, really sky high. And I'm thinking of one patient that I had, and the liver function was, I think it was 6 times upper limit normal. He didn't have any side effects at all, and he wasn't even yellow. So maybe if someone was yellow or really tired, it might, that really maybe that would really kind of clue us in that it's really severe. So again, these are easy to spot. A simple blood test can really confirm this without having the patient turn yellow or be really, really tired. But again, this is a really rare side effect that can be spotted easily. And finally, a rare side effect where the skin's involved, and this is really generalized and a lot of redness. And again, I think most of our patients and most people will alert their care provider if they don't wait until it's really bad. If you have a little bit of it, it's better to report that. So managing side effects, I kind of already talked about that. Fatigue is likely a combination of factors, and not just treatment-related. And again, if it's just treatment-related, it's not a debilitating fatigue like chemotherapy. It's usually mild, and that's the more common one. If it's really severe, that needs to be reported and not ignored, because it might clue us into other conditions. It's a good idea to hydrate, allow yourself to rest, and take naps with alternating exercise. It's also a good idea to seek help from others. There's a lot of resources. I commend you for coming in this webinar. I think I find that patients who do find help from a lot of resources, and they're out there, and if you know that helps you, then that helps you manage things better. And then also conserve your energy, and the patients that I do find cope with fatigue better are the ones that conserve it, and then when they feel the best, they try to do what matters to them most. But again, fatigue, if it's not mild, should be reported, and there shouldn't be a delay on that. I think one of the things I learned when I went back to school was that there's a lot of literature on physical activity. in any way, whether you're on treatment or not. Physical activity doesn't have to be much. It could just be 20 minutes around the block 3 times a day. It's good for everything. Your sense of well-being, it's good for your lungs. It's good for your GI tract. It's good for everything. And good nutrition is also really, really a good idea. And most of the time, if it's the heart-based diet, low in fat, high in grains, fruits and vegetables, drinking lots of fluids, that is really helpful also. Talk about nutrition, I just kind of want to go back a little bit. When someone has diarrhea, it's a good idea. One of the side, if you have a low, first is to report it, but also what helps is to hydrate and also to do a low fiber diet, like the Association of Dietetics, American Association of Dietetics has an online, and they give a really good example of a low-fiber diet, and this minimizes it. But again, it shouldn't be ignored. It should be reported. So I hope I have conveyed that to you that it's important to know your contacts, especially during off hours. Report your symptoms right away so that they can be properly evaluated and treated. When you see other specialists, communicate with them and have your doctor communicate with them that you're on immunotherapy. A really good example is this endocrine side effects that we're seeing. They're very, very uncommon, even in other populations. But we're seeing them with immunotherapy. So it's important to communicate with whoever you see that you're on immunotherapy. If you're going to show up in an emergency room, it's important to let them know and to communicate with your oncologist, and also to let them know that you're on immunotherapy, because the side effects that that might show up need to be treated differently because they're in case they're immune related. Side effects are highly manageable, and rarely they can be severe, but they can also be manageable with quick intervention. Thank you for your attention, and I now turn this over to Ms. Ellen Levine.
Thank you. I'd now like to focus a little bit on the non-physical aspects of coping with this diagnosis and treatment, and focus more on quality of life. Quality of life is a term that's used to describe, as it suggests, a broad category of all the other aspects of a patient's experience outside of the medical center and in their life day to day. So distress is a term that many of you may have heard. Sorry, I'm thinking that I was going to have these done for me, so I will. So distress, those of you who are treated in a cancer center may have heard this term. It's a term that's used more and more in the field of oncology in the recent past, because there's been a growing awareness of its impact on patients' quality of life and their ability to undergo treatment successfully. It has been shown that distress is the most underreported and common side effect of cancer. The term distress is an umbrella that encompasses many other feelings, and it can range from feelings of vulnerability and sadness and anger to problems that can be much more disabling, like severe depression, anxiety, and panic. So it's important to be aware that this can be part of the cancer experience, and to know that just like the physical symptoms that are addressed commonly, that these are feelings that can also be managed successfully in a variety of ways. There are certain time periods during an individual's cancer experience when stress is typically most acute. One of the most predictable times is, of course, as one would expect, at the time of the initial diagnosis, a very stressful time. In addition, the next very predictable time of distress is when a patient is faced with having to make a decision regarding treatment, when they're being inundated with information, advice, and can be a very confusing and stressful time. Many people find that it is a bit overwhelming, and it's hard to know what questions to ask of the doctor and the medical team. So what people have found to be extremely helpful is to be well prepared. So that doesn't necessarily mean just researching on the internet or going for multiple opinions. What it means is to be prepared with a comprehensive list of questions that the patient, that if you are the patient, that you feel are important to you to be able to get answered to help you in making your decision around treatment. So having a list of questions can help the patient feel more organized, more comfortable, and be able to work as a team with your doctor to be able to make a decision about what treatment is right for you. Cancer support community has developed a decision support counseling program that's called Open to Options. And this was researched for many years and is now a program that is offered throughout our affiliate network. And what it does is it helps an individual to be able to prepare for an appointment, an upcoming appointment that a patient will have, at which time a decision is being made. This Open to Options program can be done face-to-face if you live near a cancer support community affiliate, but it can also be done by telephone, either with a local affiliate or through our helpline. And you'll see on this slide that the phone number is on there, 1-888-793-9355. The research has shown that when patients are well prepared and bring this type of question list with them to their appointment, that both the patients and the healthcare providers have found that the appointment can be more productive and less stressful, and allow the communication to be much more effective, and importantly, to give the patient a greater feeling of control. The question list is organized in a way, typically on just one sheet of paper with the help of the cancer support community trained clinician, one sheet of paper with several categories of questions that the patient is able to identify in this interview, and the clinician is able to help tease out what other questions they might have. So it's a very effective tool. It's a free service that we offer, and I certainly would encourage people to take advantage of it. This can also be done, the Open to Options intervention can also be done at other points in the cancer experience, not just with the initial diagnosis. If a patient is faced with a recurrence of their cancer, or if there is some type of a change in treatment that's being discussed, the Open to Options intervention can be very helpful to, again, relook at, okay, what are the questions that I have, and what do I need to consider and bring to my next appointment with my doctor. So this is not just a one-time intervention, but can be done at a variety of times in the cancer experience. So I want to just talk a little bit now about dealing with stress, something that is just a reality in all of our lives, but certainly going through cancer, and if one is going through metastatic cancer, that stress can be very much a part of the experience. So I'm just going to go through some tried and true kinds of suggestions, things that have been shown to be effective, and certainly is not unique to the cancer experience. So if those of you who are listening might be caregivers or family members, these are things that can also be generalized to the realities of dealing with the stress of being a caregiver to a loved one with cancer. So being proactive is so critical. So taking action and feeling that there is something that you can do. Be able to partialize, to take a large problem and make it into digestible bits. So making plans to manage one problem at a time. That first bullet really speaks to being able to find ways to take control of some component of one's life, to be able to feel that will decrease the stress a bit. We've talked earlier about the value of seeking information and getting advice. So the idea of just basically becoming informed in whatever way the individual patient feels comfortable. Some people are tremendous information seekers, and it really helps them feel more at ease. Other people find that they prefer to ask for advice from their medical professionals and be guided more fully. But whatever amount of information the patient feels comfortable with, that can be a very effective stress management technique as well. Again, giving a feeling of control. There is a tremendous array of stress management techniques that are available to all of us. In the cancer support community, we use the term to become patient active, which is an extension of taking control, but also to be able to learn coping strategies to be able to manage the stress of going through the cancer experience. So whether it be relaxation techniques, exercise, journaling, whatever it might be. For others, it may be spirituality. For some, it may be being with family and friends. Others, it might be spending time with a pet. But whatever stress management technique one finds to be helpful, that can be another very effective approach. Being prepared to manage the side effects by seeking advice and support when needed. So this is not just the physical side, which there has been much attention in this webinar, but also the emotional burden. So to be ready and willing to ask for help, and that would include on the emotional impact, because by asking for help and getting help, that can also help to lower the stress. Certainly, there are tremendous role changes that can occur during a cancer experience, and so asking for help and accepting help can be a very difficult thing for people to do. But recognizing that that's a normal part of the experience may make it a little bit easier to be able to ask for help. For a man in a more traditional role in a family who's accustomed to being the provider and working, and now perhaps being more of a patient and not being able to do all the things that he's accustomed to doing, being able to ask for help. And similarly, a woman who may be accustomed to being the nurturer, needing to be able to, as a patient, learn to be able to accept help and being able to ask for emotional support. So these are role changes that it's important to at least recognize, because that can then give one a sense of control. Again, that's that theme about gaining control in a situation that often feels very out of control. And then lastly, being able to seek help when the emotional impact of the cancer becomes really difficult, whether it be manifest through anxiety or depression or other symptoms that might impact eating, sleeping, just desire to do one's everyday activities, that would be a time to consider talking with your doctor or social worker or other healthcare professional or mental health professional to be able to seek help. So what kind of support is there out there? Again, this is very much tailored to the individual and what one feels comfortable with. There is a range of help. Sometimes it's helpful just to talk to other cancer survivors, other people who have had immunotherapy, other people who have dealt with similar side effects, similar role changes, whatever component of the experience is most troublesome, to be able to contact one of many cancer organizations to be able to ask for some peer support. Peer support can also be gained through support groups. And, many people will say, oh, I'm not a support group kind of a person. that's where the one-on-one counseling may be helpful, or even some online support. So nowadays there are so many different ways to be able to get support that hopefully if someone is struggling emotionally, they will consider the breadth of offerings, and if they're not certain, ask a clinician to help them sort out what might be the best fit for them. For some people, they are more comfortable being able to find support from within their family and friends, and recognizing that their relationships certainly may be impacted. Family support can be helpful, but it is important to be aware of those changes, recognize that like a stone in a pond, that the impact of cancer reaches in many directions, to close family, to children, to parents, to close friends and neighbors, co-workers. So again, for those of you who might be listening who are in those roles, to recognize that treatment and attention to your emotional issues is important as well. Cancer is an experience that can make people feel very alone, and but yet when one is able to reach out and ask for help, the communication often does help to open up and to provide greater support with one's loved ones. Lastly, I'd like to speak about the concept of hope. Hope is something that I'm sure for those of you who are patients, it's recommended often. People say, oh, be hopeful, stay hopeful, there's always hope, and it's thrown around an awful lot. Well, as a patient, I think most people, or a cancer patient, if you do have metastatic disease, hope is a very tricky word, but I can assure you that there are ways to redefine hope, and it can change over time. Initially, the hope may be for a cure. Throughout the experience, there may be a hope for good quality of life, for not having significant side effects or managing side effects adequately to be able to enjoy one's relationships and friends and family. If one is faced with limited treatment options, there may be hope for comfort and for the ability to have good relationships and good time spent. So I think it's important from time to time to just recognize that word hope can be redefined and it can change. Again, being able to look at the balance in one's life, both physical activity, diet, relationships, that all these components, emotional health, all contribute to one's quality of life. And finding ways to be able to express one's emotions, both positive and negative. It's needing help to get that ability to speak those emotions, but that can be very helpful in improving one's quality of life, because there is always a way to find meaning and quality in every day. So this last slide, which will be available on our website, lists a number of organizations that have many other resources, both work-related, support-related, research-related, advocacy. So you may want to take the time to check out those websites and see what additional resources would be available to you. Now I'd like to turn the talk over to Rhea Suarez.
Thank you, Ellen. So now we'll begin our Q&A session. Again, you can type a question through the Q&A box to the right of your screen. Just give me a couple minutes while I poll for some questions. And for our speakers, I'm going to unmute you at this time so that you can go ahead and answer the questions that we do receive. Okay, so our first question for Dr. Salama. My sister's been diagnosed with stage 3 melanoma and is due to start interferon therapy. Is this the latest therapy recommended?
So without knowing all of the specifics of your sister's case, you kind of make some general recommendations. I think interferon is considered a standard therapy for many patients with stage 3 melanoma that's been removed by surgery. So meaning by stage 3, we usually mean that the cancer has spread to the lymph nodes and that it's been removed. I would say also clinical trials may be a good option in terms of talking with her doctor about any potential clinical trials that she may be eligible for. Because of the side effects of interferon and because it doesn't benefit the majority of the patients, some patients will opt for sort of close observation, and that's sort of dependent upon your exact type of stage 3 melanoma and how much cancer was in the lymph nodes in terms of follow-up with your dermatologist or your surgeon or a medical oncologist or potentially getting scans. But I do think interferon is one potential treatment option.
Okay, great. Thank you. We have another question for you, Dr. Salama. The PD-1 inhibitors are for patients whose tumors have spread, but what about patients whose tumors have gone away using Tafinlar, which has shown to lose durability at 9 months or so? Why must a patient wait for tumors to return?
This is a great question, and it has a lot to do with what we were talking about in terms of the breakthrough status and kind of the accelerated approval that we've seen with the PD-1 drugs. So right now, pembrolizumab or Keytruda is approved based off of an early phase or a phase 1 study, even though it was actually a pretty large phase 1 study that included over 100 patients. But to get onto that study, at that time, those patients had to have tried prior therapies, including ipilimumab, and if their tumor had a BRAF mutation, they had to have tried the BRAF inhibitors, something like Tafinlar or one of the other BRAF inhibitors, and then shown that their tumor then became resistant to those therapies. And because that was the patient population that was kind of tested in this earlier phase trial that showed this promising activity for pembrolizumab, that's the indication of which the FDA has based this sort of recent approval. I don't think it will always be that way, but we're still waiting for the final results of some other studies on giving pembrolizumab or other PD-1 drugs as the first line of therapy. So right now that is where it stands in terms of the FDA labeling.
Great, thank you. This question is for Ellen. Ellen, my father has metastatic melanoma, and I'm concerned that he's overwhelmed due to his diagnosis. Do you have any recommendations so that I can help him feel less overwhelmed?
Yes, I do. That's a hard one because it's understandable, and it's your dad, and he may not be comfortable talking about it because he's the dad. So if he's not willing to talk with you and accept ideas for ways to get help, I would say bring it up, bring it to the doctor's attention. Perhaps if you go with your dad to the doctor, ask the doctor to address this. As I said earlier, there are many different ways that people cope with stress, and some people are more stoic and don't want to accept help, but I think everyone appreciates it being acknowledged and being offered ideas. And then hopefully he will accept some help, even if it's talking with another patient. Sometimes it's easier to talk with a healthcare professional or mental health professional than it is with a family member, because family members often want to protect one another from those scary feelings. So starting by talking with him, encouraging him to bring it up with the doctor, or you with the child bringing it up with the doctor, and seeing if other help can be brought in.
Great, thank you, Ellen. We have another question for Dr. Salama. What are the up-and-coming clinical trial drugs and treatments now that pembrolizumab has been approved, and it looks like nivolumab will also be approved. In other words, what is the new IT treatment, if any?
So that's a great question, and it's probably a number of things. I certainly think combination therapies show a lot of promise, and there's been some early data that's presented around giving things like ipilimumab and PD-1 with nivolumab together that have shown high response rates, although there's also potentially a higher rate of toxicity, so we sometimes can't rush to conclusions, although it is very promising. And then along the lines of immunotherapy specifically, there are other breaks, so other checkpoints. We've talked about CTLA-4, we've talked about PD-1, but there are a number of others that may interact as well, and we'll, I think, largely be looking at combinations, both with immune therapies and targeted therapies.
Thank you. We have another question for Dr. Salama. If clinical trial was used, IPI and Nivo combo, will there be a possibility of using Pembro in the future? If disease progressed, can a PD-1 inhibitor be duplicated?
So it's a great question. I think it's one that's not known right now. I think my bias as a clinician would be that if someone's tumor has grown after blocking it in one way, so with either nivolumab or pembrolizumab, my bias would be to try to target it from a different angle and potentially not repeating the same antibody, although I should say that's different than for patients who had a response and then took a break for other reasons. So sometimes patients on these drugs, we take a break for reasons other than their cancer is growing. They maybe are having side effects or other issues that they can't keep going with treatment. And there's been some early data to suggest that we can retreat both with IPI sometimes and PD-1 to kind of induce another remission. Two different situations.
Thank you. Grace, this question is for you. I'm experiencing very difficult side effects from radiation I received the beginning of August. Is there something I can do to start feeling better? I'm not sure of the specific side effects that she's experienced, but is there anything that she can do to start feeling better?
Not knowing what those specifically are, I'm not sure how I can address that, but I would definitely have yourself checked out. Radiation, depending where you got it, if it affects the long bones, you might have some anemia. If you have, I'm not sure if you're talking about skin side effects. But you can, and I'm not sure what treatments you've had in the past. Have you had an immunotherapy, and you may be experiencing delayed side effects? So my best suggestion is to check with your doctor so they can do a proper evaluation. They'll probably do a blood test. They'll listen out for specifically what symptoms you have, and if they need to do imaging, they can do imaging so they can properly evaluate and properly treat whatever it is that's going on.
Great, thank you. Ellen, you may have touched on this before, but are there any programs to help me deal with stress of diagnosis and treatment?
I did, but it bears repeating. The last question was more about the caregiver, and that would be to consider talking with the healthcare professionals, asking for what's available at your cancer center or in your community in terms of organized kinds of support, mental health support groups. Or certainly if that feels too overwhelming, too much, to just look at your own life and say, well, gee, how have I coped with stress in the past? What are the things that have worked for me or can work for me? As I mentioned examples before, some gentle activity, some spirituality, attention, journaling, spending time with friends and family, all very basic, but those often can be extremely helpful. And it's easy to forget that those are things that can be very helpful.
Thank you. Dr. Salama, although I realize not indicated, could these therapies prove useful for patients with stages 1 and 2 in the future?
So that's another great question, and this is sort of where the field is moving, is in thinking about now that we know we have active therapy, could it be used to prevent recurrence? I think the concern then always comes with worrying about the toxicity, and as Grace did such a great job of going through some of the potential side effects, many of which are mild, but there are some very serious and some life-threatening side effects from these drugs, and so we really need to, select which patients we should think about giving them to. And so early stage melanoma, especially stage 1, nearly 98 or 99% of those patients are cured with surgery alone. Certainly there are some stage 2 patients, and those are patients with primary tumors that are a little bit thicker that are potentially could be at higher risk, that it's something that can be considered, and that's being tested in some clinical trials at this point, although it's very, very early.
Great, thank you. Dr. Salama, can you talk more about nivolumab, about what's been found in those trials?
Absolutely. And so nivolumab, we kind of talked a little bit about pembrolizumab just in light of the recent FDA approval, but nivolumab is another PD-1 antibody, so it's another, just like pembrolizumab, another antibody that targets that brake on the immune system. And similar to pembrolizumab, it's shown very promising results in nearly about a third of patients that have been treated. And similar to some of the other immune therapies, we think that these responses are durable. So at 1 and 2 years, the significant proportion of these patients are still experiencing responses. And so it's also been designated sort of for that fast track or sort of that status through the FDA as well, and it's being actively studied in clinical trials. So I think of it as a potentially, hopefully another option for patients.
Thank you. So are melanomas more prevalent in people with both a family history and either a primary or autoimmune deficiency, Dr. Salama?
That's another kind of good and a tough question. So for us, it's hard to tease out how much is genetic in melanoma. Certainly there is a genetic predisposition, but there's not a melanoma gene that's been identified like a breast cancer gene, because people also tend to share some of the similar risk factors we know for melanoma, like hair color or light skin color or light eye color, and it's sort of in a way indirectly related to melanoma risk. Families also share same sun exposure patterns, so they live in similar areas and may have similar rates of getting sunburns or exposure to the sun. In terms of specific autoimmune deficiencies, I think maybe they're referring to here for patients who maybe have either an immune deficiency, and we know that those patients in general are at higher risk for getting many different types of cancer, including melanoma. But if they're asking more for an autoimmune diseases, so patients with things like rheumatoid arthritis or lupus or other immune diseases, those patients are not specifically necessarily at increased risk. Though some of the medications that they take to treat their autoimmune disease may put them at higher risk for developing other cancers.
Okay, great. And we've got time for one last question. I've read a lot about immunotherapy, and I'm curious to know about long-term remission, or what's been called durable or complete response. What therapy or therapies can offer someone with advanced melanoma the chance for recovery? Dr. Salama.
So right now, I would say all of the immunotherapies have that potential, and that includes the more traditional types of immunotherapy, like high-dose IL-2, which has actually been around for quite some time, and we actually have the most follow-up data for IL-2. It's a minority of patients. It's probably around 5%, but we definitely know there are those patients that can have long-term durable responses ongoing for decades. We obviously have less of that data with IPI, which has been around for a little bit longer and was in clinical trials sort of in the early 2000s, and then we have even kind of less of that data in terms of true long-term follow-up patients that have received the PD-1 agents. But at this point, we have 1 and 2, and for IPI kind of fairly robust 3-year survival rates, which tend to suggest that 20 to 25% of patients can have a durable response. And often we feel in oncology, when we're seeing responses out that long, that we feel like those would continue to be durable. But obviously we would need more time to definitively tell.
Mm-hmm. Okay, great. I do have one last question. Is there any research to support one anti-PD-1 therapy versus the other, Nivo or pembrolizumab? Has research been done that combines the two anti-PD-1 therapies?
So no, I would say we don't yet know if one is better than the other, and my own personal opinion is that they're both probably pretty equivalent, and studies have not yet been done looking at combining different types of PD-1 antibodies specifically.
Okay, great, thank you. All right, so I just want to say thank you to everyone for your enthusiasm and questions that have contributed to making today's webinar a great success. If you'd like more detailed information, please feel free to check out our free Frankly Speaking About Cancer, Your Immune System, and Cancer Treatment fact sheet, which is available to order or download on our website, cancersupportcommunity.org. Also, please feel free to visit our website or call our toll-free helpline if you have any additional information. Again, we'd like to thank our wonderful speakers, Dr. April Salama, Grace Cherry, and Ellen Levine, for contributing their time and sharing this important information with us. We'd also like to thank our partners, AIM at Melanoma, Melanoma International Foundation, Melanoma Research Alliance, and Melanoma Research Foundation. CSC would also like to thank our program supporter, Bristol Myers Squibb. Please take a moment to complete our post-webinar online survey, which you will be redirected to. It's a brief survey, and we greatly appreciate any feedback that you may have. Thank you for your participation.
Thank you.
Thank you.